Yeah, hello and welcome to video 29 in the Tulip Airway channel. Today we're imagining a world where you only have one airway device, not four. So the problem is at the moment we have Guedels, we have laryngeal masks, we have iGels, we have ET tubes, we have probably too many airways, and they all basically trying to solve the single problem, all of these singular ones. I think we'll exclude the endotracheal tube because that does a specifically different job, but largely the Guedel, the face mask, the iGel and a laryngeal mask, they all do roughly the same thing. But imagine a world where you had an airway, it worked, you didn't need another airway, like a needle and a syringe, it works. Well, that is what a Tulip Airway is designed to do. All right, so we're talking about, an improvement of logic and safety, some economic benefit in replacing several different airways in stock with simple, simplification of one airway. The main problem, of course, is inefficiency, but, even more important than that, than the expensive nature of the intervention, Guedel and mask, followed by an iGel or an LMA, or I mean, as I said, I extubate deep with LMAs and iGels replaced with Guedel masks because I don't like the gagging and the biting. But there's also the additional complications to consider when you're swapping things around, when you're moving, you're traumatizing. No, but the Guedel face mask, I mean, it's a very basic airway. 1933 it was invented in. Usually in the hands of non-anaesthetists, the seal is very poor. In the hands of non-anaesthetists, several people need, two hands just to hold the mask and therefore two people to ventilate. One person holding the mask with two hands, the other one squeezing the bag. Ventilation is limited. You need high pressures because it's such a narrow, high resistance airway. Now, the iGel is good for unconscious patients, but you can't use it in semi-conscious. You can't use it for induction and recovery. You can't use it in, the drug-induced sedation, the unstable COPD in A&E, you need a depth of anesthesia for an iGel. The LMA is, the same. It's an effective device for starved elective anesthesia, but it's still supraglottic. You still need to be fully unconscious to suppress the reflexes far enough for a patient to be able to tolerate it. So what happens is clinicians are forced to swap between airways and escalate or de-escalate according to conscious level because it's the patient's conscious state that demands that change. But the problem isn't the devices, it's the fact that they're based around that same assumption. You've got semi-conscious, then you've got unconscious. And for a majority of these devices, other than the Guedel, the patient has to be fully, or deeply unconscious. But the Tulip changes that assumption because the Tulip is semi-conscious all the way to unconscious. It's directly connectable, But the main benefit of the Tulip and how it's able to do this is it's an oropharyngeal seal. So it's much less stimulating than supraglottic devices. The Tulip and its cuff sits behind the tongue, so that's within the glossopharyngeal nerve distribution. That means it doesn't make you cough, it doesn't make you gag, it makes you swallow, and that's why you can be tolerated in semi-conscious states. And it's important that this is the key differentiator. This is how a Tulip can replace a Guedel mask and an LMA and an iGel, e.g. how it can go from semi-conscious all the way to unconscious and back. So, but the Tulip doesn't just, provide, it provides a seal internally. It doesn't provide just an airway. It's like a Guedel is an airway, but a Tulip gives you a stable ventilating airway, which is hands-free. It's directly connectable, and because of that, you're getting tidal volumes of plus 77%, 101% greater CO2 elimination. But the Tulip doesn't require deep anesthesia like an iGel does. So, a Tulip works in the lighter planes. You don't need a fully unconscious patient. So induction, recovery, pre-post intubation, for the whole of, starved elective anesthesia. So, again, like, unlike the laryngeal mask, Tulip's not supraglottic, so it doesn't sit down here, it sits up here. I bet you can't see my finger there, but there. So basically it's a completely different anatomical location, so it gives you a a different level of tolerance in the semi-conscious. You know, it enables self-extubation when they're fully awake. GCS 13, 14. But it's about the clinical consequences. It's not just like, oh, let's just do this for fun. You know, it's convenient how easy that is. It's about how you intervene, how often you intervene. It's about the escalation, de-escalation that we're forced to do between semi-conscious and fully unconscious. So there's less escalation, de-escalation, right? So there's you don't need paralysis, you don't need deep anesthesia, and you get that intact reflexes on a fully awake recovery. Okay, now the seal of a tulip is oropharyngeal, and we've tested this with bronchoscopes, fluorescein, ultraviolet light, and that includes 2-hour septoplasties for ENT. The recommended cuff pressure of a tulip is 50 centimeters of water, which is 40 millimeters of mercury, and that's the same as mucosal perfusion pressure. So, technically you could leave the tulip in ad infinitum. You can increase the cuff pressure to 100 centimeters of water for ENT protection if you think that there's a particular risk, but it's only recommended to be done briefly. So, from my point of view, this is a kind of a thinking shift moment. Why we have so many airway devices? Why is it necessary? So, if you're an anaesthetist, if you're a hospital, if you're a clinic or a distributor who's interested in trying the Tulip, get hold of us at info@tulipairwayco.uk. This is the website. Speak soon.